Good afternoon, everyone. My name is Utkarsh, and I'm a research fellow at University of Oxford. I just wanted to welcome you all to this lightning talk session, and I have with me six wonderful speakers who will be talking about their respective research, which they have done over the past few years, and they have done a fantastic job of it. I'll come about introducing each speaker one at a time, but before that, I just wanted to let everybody know how we decided to select our six speakers. So it was a fair process, which was a blind review process, and we had multiple applications come in. And then we had five reviewers who went through each application, and two reviewers scored each application. And then we selected six top speakers who are really representing a wide community, starting from PhD students through to senior researchers. So the order of these speakers will be Yasmin, who is a research fellow at Lancaster University. Then we'll have Sarah, who is a senior research fellow in biomedical data science and health informatics at University of Oxford, followed by Marta. She is a PhD student at Queen's Mary University of London, followed by Hannah, who is a research associate in epidemiology at Imperial College. Next, we'll have Hadley. She is a scientific content creator at LifeBit Biotech Limited. And lastly, we will have Anuradha. She is a research fellow at University of Birmingham. Once all of our speakers present their research, there will be a voting icon which will pop up at the top hand right side of your corner, and then up until 2:15, which is just when the lunch ends, then up till that point, everybody can vote who the best speaker is. I'll come to I'll open the voting. I'll let everybody know when the voting link is open. And please do remember that once you have voted, you won't be allowed to vote again. So I'll hand over first to Yasmin, who's our first speaker. Over to you, Yasmin.
Hi, thank you all. Thank you for this opportunity. I will be talking about the Cancer Research UK funded cancer loyalty card study. The evidence behind this research is that, unfortunately, 1 in 4 ovarian cancer patients are diagnosed at a late stage when treatment options are less than optimal for survival. Late stage ovarian cancer diagnosis is often linked with patient presentation, delayed patient presentation, and longer diagnostic intervals due to its non-specific symptoms such as bloating, indigestion, abdominal pain. And in relation to this, qualitative evidence suggests patients often self-care for their symptoms prior to diagnosis. Unfortunately, the problem with this data is that it is often self-reported and qualitative, so it's harder to understand the timeline and patterns of self-care behaviours and come up with interventions to facilitate health seeking. However, the GDPR offered an opportunity in 2018 with something called subject access request, allowing researchers or individuals to request their data from real-life data from other resources. So we come up with this idea to think about, okay, what if we can use shopping data to understand these behaviours, self-care behaviours? And as one of its kind, it was harder to sort of identify whether people would be willing to take part or not. So that was our question. So we come up with a case control study, including individuals with and without ovarian cancer. And we partnered with 2 UK-based high street retailers with loyalty card schemes. And from these questions that we were about willingness, we carried out some public acceptability studies and experiments to understand how we need to recruit participants. And we identified 1 in 2 people are willing to share shopping data in comparison to wearable devices and internet data. However, the willingness reduced by age, and it was integral for our communication strategies to make sure that we need to build trust with the public to understand the value of this research and also be very transparent about how we're using their data through retailers. In the end, we recruited 183 cases through NHS clinics and 427 controls through paid social media advertisement. When it comes to actually requesting data from the retailers, we come across with a problem called identity verification, which then reduced our numbers to, sorry, the slides are so small, I can't see, 150 cases and 120 control participants. However, we were still able to age match these controls and go back 2 years from the date of cancer diagnosis. And our results demonstrated that between the sort of individuals with ovarian cancer and without ovarian cancer, about 8 months prior to cancer diagnosis, there's a significant increase in pain and indigestion medication purchases. Obviously, this doesn't mean consumption, but when we sort of looked at it in detail, we identified that this probably provides an opportunity, window of opportunity to facilitate early help seeking between 5 to 8 months of diagnosis, and that could mean for someone treatment options if they're diagnosed a little bit sooner. Thank you very much for this opportunity, and you can find out about our study on clocksproject.org.uk. Thank you. And I will now hand over to Sarah.
Well, thank you very much. On behalf of the CVD COVID-19 Consortium, it is a pleasure to present this study on ethnicity, health equity, and artificial intelligence. Inequity in UK healthcare was highlighted by the COVID-19 pandemic, where people from ethnically diverse backgrounds in the UK were disproportionately affected. But we know that inequity is not limited to COVID. It's a long-standing, even global, multifaceted issue. One factor is inequity through health technology. For example, artificial intelligence for clinical risk prediction that may be used by doctors to decide patient care. If there's bias in the data or bias in the modeling process, this decision-making can, and ultimately patient outcomes can be impacted. So in this national core study, the aim was to start at source, that is by studying ethnicity data available in health records with regards to their completeness, consistency, and quality. So through secured access to the National Health Service's digital trusted research environment, it was possible to study over 60 million anonymized GP records from England, where ethnicity is coded using SNOMED CT concepts and further grouped into 18 groups or 9 or 6 groups following further ethnicity classifications used by researchers. So ultimately, over 250 medical concepts of ethnicity groups are used in clinical practice. These groups can vary in size, detail, and they can have overlaps. There is agreement with the latest census estimates in terms of the largest ethnicity groups being found were white, Asian, and Black. However, with a higher proportion of individuals in mixed and other ethnicity groups, these health data were found to be more diverse than census data, although these numbers are just for England. Further, 1 in 10 people were found not to have an ethnicity record at all in either GP or hospital records. And this well exceeds historical levels of completeness when it comes to ethnicity in real-world health data sources, both in the UK and internationally. Now, why is this important? The UK population is increasingly diverse and with potentially different health profiles and needs. Grouping everyone into broad ethnicity groups is sometimes not enough to understand the underlying picture of all of our health and indeed all of our future risks. And this is something that was made clearer by working together with patients, carers, and health experts. And in the words of one of our patients in this video,
I was diagnosed with gestational diabetes in my pregnancy, which meant that I had to go to a diabetes clinic every other week. It was there that I was told that my community was quite prone to diabetes. If I hadn't completed the paperwork that asked about my ethnicity, I would never have known how big a problem diabetes is in my community and received the care I needed.
So researchers, health researchers can now study ethnicity data for over 9 in 10 people in the UK population to inform their research. Better data, we feel, could lead to better research and ultimately better personalized care for everyone, ensuring that no one is left behind. Thank you very much. And I will now pass on to our next speaker.
Good afternoon. Hello, my name is Good afternoon. My name is Marta. I am a PhD student at Queen Mary University of London. Today, I will be talking about how housing conditions affect health and how they contribute to health inequalities. Specifically, I will focus on the relationship between living in overcrowded housing and the likelihood of catching COVID. I asked the question, are the people who live in overcrowded housing more likely to catch COVID? So why is that important? We know that living in poor quality housing can contribute to worse physical and mental health and well-being. We also know that the recent pandemics increased the health inequalities. People in Northeast London, the area with high levels of overcrowding and high levels of deprivation, experienced some of the highest levels of COVID-19 infections. Also, Londoners live in one of the most overcrowded homes in Europe. In pandemics, we were all confined to our homes. But still, there is little research on the relationship between overcrowding and COVID-19 infections. So what did I do? I used the health data of almost 900,000 adults that are registered in Northeast London GPs, and I calculated the number of people in households. I also used the novel method of de-identified linkage between health and housing data that included the properties areas. This allowed me to calculate the area per person in the London households. The households were overcrowded if the area per person in Northeast London households was lower than 32 square meters per person, which is the rough equivalent of 3 supermarket parking spaces. So what did I find? Firstly, 3 out of 4 people in Northeast London live in overcrowded households. Secondly, people living in overcrowded households are more likely to catch COVID than people living in non-overcrowded households. Also, people from South Asian backgrounds and people living with children are more likely to catch COVID, even accounting for overcrowding. This research needs to be confirmed on other populations, but it already shows the importance of considering overcrowding as a risk factor in infections passed through close contact between people. So how are we using this research? We presented the findings to the public involvement members of our collaboration with Tower Hamlets Council. This collaboration will also use these findings to investigate warranted determinants of health, as well as to inform the development and evaluation of housing policies, including social housing allocation. In conclusion, I asked, are people living in overcrowded households more likely to catch COVID? And this research shows that yes, they are. Thank you very much for your attention. Thank you to my early child health team, all the patients who contributed, Queen Mary University of London, and Barts Charity. Thank you. And now I will hand over to Hannah.
Classic. There had to be one. So good afternoon, everyone. My name is Hannah Whitaker, and I'm a postdoc epidemiologist at Imperial College London. And my work to date has focused on how people with chronic respiratory disease are managed in clinical practice using anonymised, routinely collected healthcare data in the UK. But since the start of the pandemic, I've been interested in investigating the long-term effects of COVID and how people with COVID are managed in clinical practice. And research to date has shown that people with COVID are more likely to develop cardiovascular disease and have cardiovascular disease events such as heart attacks and strokes compared with people who don't have COVID. But we wanted to take this one step further to investigate whether there are specific populations of people who are at risk of cardiovascular disease after they are infected with COVID compared with others. So the first thing that we did was engage with patients and members of the public about what was important to them to understand the relationship between COVID and cardiovascular disease. And from there, we developed 2 research questions. The first was whether people with pre-existing chronic respiratory disease were more likely to have cardiovascular disease events after COVID compared with people without pre-existing chronic respiratory disease. And second, whether the COVID vaccine affects this risk in either group. So to do this, we used a wide range of routinely collected data sources in England, all of which were anonymized. We used primary care records, which contain information on processes occurring at the GP. We used hospital records, which contained data on processes occurring in hospital, as well as accident and emergency visits. We used mortality information from death certificate records. We also used COVID vaccination records, which contained information on when people were vaccinated, with which vaccine, and what dose number this was. And finally, we used COVID laboratory records, which contained information on both positive and negative COVID test results. And using this data, we defined a population of over 3 million people who had been infected with COVID prior to being vaccinated between January 2020 and November 2021. And of these people, we characterized a population of people with pre-existing chronic respiratory disease prior to COVID. And this was defined as a diagnosis of asthma, chronic obstructive pulmonary disease, bronchiectasis, cystic fibrosis, as well as interstitial lung disease. And we also characterized a population of people with no pre-existing chronic respiratory disease. And people with and without pre-existing chronic respiratory disease were followed up to assess whether they had a cardiovascular disease event. And so overall, we found that people with pre-existing chronic respiratory disease were 7% more likely to have a cardiovascular disease event after COVID compared with people without pre-existing chronic respiratory disease. And second, being vaccinated for COVID reduced the risk of having a cardiovascular disease-related event by a similar amount in people with and without chronic respiratory disease separately. And so in summary, whilst people with pre-existing chronic respiratory disease had a slightly higher risk of cardiovascular disease after COVID, this risk decreased after the COVID vaccine. And I'd like to thank the Data and Connectivity National Core Study, the British Heart Foundation Data Science Centre, and all my collaborators for helping with this piece of work. And if anyone has any questions or would like to discuss this project in more detail, please don't hesitate to contact me. Thank you for listening, and I'll now hand over to Hadley.
Great, thank you for that introduction. I work for a company called LifeBit, and we're a biotech with a computational platform that's making sensitive biomedical data accessible and usable. And this is important because much of this data has been siloed and protected in order to preserve patient privacy, which has slowed research progress. And so as a company, we're challenging this paradigm by making the data accessible and usable. And so today I'm going to highlight our collaborative effort with the University of Cambridge, Eastern AHSN Hospitals, Genomics England, which was funded by the DARE UK program via UKRI and HDR UK. And so prior to our DARE UK effort, LifeBit has been thrilled to partner with Genomics England and NIHR Biomedical Research Center individually. Genomics England is a national biobank hosting over 130,000 consented patient genomes from NHS patients. And NIHR Cambridge is an academic institute that also holds valuable biomedical data. We've been able to deploy the trusted research environment for each of these institutions using federated technologies. So we don't have to move or copy the data. We make a virtual link between the researcher and the given institute so they have secure access. The problem with this, though, prior to our DARE UK efforts, is that Genomics England and Cambridge wanted a way to collaborate. And so to achieve this, our consortium sought to use multi-party federation. So now not only is a researcher linked to a single institute, but actually the two institutes can communicate as well, giving the researcher greater access to data. And this was important because multi-party federation had never before been achieved in the UK between institutes such as this. And so I'm going to walk you through how this worked with our technical blueprint. So a client user could log on to the LifeBit platform from either of these institutions. And if they had the correct authorizations, they would receive access to the trusted research environments of Genomics England and Cambridge. They could browse that data and say identify subcohorts of all women over the age of 35 that might have been affected by breast cancer and conduct their required analysis to answer their research questions. Once that analysis is complete, the aggregated results will end up in a safe haven within Genomics England's trusted research environment. And this is a security checkpoint where the airlock policy allows a data access committee to confirm that there's no identifying data that will be leaving this trusted research environment. And if the checkpoint is passed, then those results are returned to the user. And again, this is just aggregated data. And so we were able to achieve this goal and actually perform a live demonstration of this. But I think what's the most important is we've developed an open source technical blueprint of how this can be achieved. So other institutes can do this as well. We engaged with the public and patients in order to hear their thoughts about how we should think about using sensitive biomedical data. We had a patient collaborator sitting with us throughout the entire duration of this project. And furthermore, we conducted routine outreach events. And so this is really exciting. Now Cambridge and Genomics England are able to collaborate, but furthermore, multi-party federation is poised to scale research to limitless capabilities. We can grow this beyond just two institutes, and so researchers will have much greater access to data that can ultimately drive research progress and ultimately benefit patients. And this is something that I find really rewarding in being a part of this effort. And so with that, I want to thank the consortium for all their amazing work, as well as my company. And I'd be happy to answer any other questions after this session. So thank you again. And with that, I will pass it on to Anuradha, who's going to talk about her work.
Hi, everyone. Good morning, good afternoon, good evening, depending on where you are. I'm Anuradha Subramanian, and I'm incredibly delighted to join you all today virtually at the HDI UK conference. Availability of contemporary data, especially during the COVID-19 pandemic, has been phenomenally resourceful. I will be presenting now the findings of a piece of research from the Therapies for Long COVID study that was possible due to timely availability of such data. This study, funded by NIHR, explores the range of symptoms and risk factors of long COVID and how these symptoms cluster together, possibly reflecting the different phenotypes of long COVID. Using the Clinical Practice Research Data Link ORAM database, which is data acquired from roughly 7% of the general practices within the UK, we, researchers at the University of Birmingham and a range of collaborators, including CPRD and Apparato, conducted a retrospective matched cohort study of over 400,000 patients with a confirmed diagnosis of COVID-19 within their primary care records and 1.9 million patients without a record of confirmed or suspected COVID-19. We collected comprehensive data on demographics, clinical diagnoses, and symptoms that were recorded at baseline and used this data in a propensity score model to obtain two cohorts, exposed and unexposed to SARS-CoV-2 infection, that were very similar in terms of the variables that were included in the propensity score model. We then went on to assess the incidence of 115 symptom outcomes that were persistent after 12 weeks from index date for both the cohorts. 62 of the 115 symptoms were statistically significantly associated with exposure to COVID-19 in the longer term. These are presented in a word cloud on the left, wherein the text size of the symptom represents its strength of association with COVID-19 exposure in the longer term. Notably, the 62 symptoms span across 14 different domains, ranging from fatigue, pain, respiratory, mental health, cardiovascular, gastrointestinal, and sexual health symptom domains. Top 10 strongly associated symptoms with COVID-19 exposure is denoted in the forest plot in the middle, And these were loss of smell, hair loss, sneezing, ejaculation difficulty in men, reduced libido, shortness of breath, even at rest, fatigue, pleuritic chest pain, hoarse voice, and fever. We then estimated the incidence of a composite outcome of symptoms, including the WHO case definition of long COVID, within the two cohorts, and found that there was a 26% increased risk of this outcome among the COVID-19 exposed cohort. We also derived a composite outcome post hoc defining long COVID, which is the reporting of at least one of the 62 significantly associated symptoms after 12 weeks from index date. There was a 29% increased risk of this post hoc defined composite outcome of long COVID among the COVID-19 exposed cohort compared to the very similar propensity score matched unexposed cohort. The risk factors of this composite long COVID outcome measure was an estimated younger age, high BMI, female sex, belonging to an ethnic minority background, or being deprived were some of the demographic risk factors of long COVID. In addition, a range of comorbidities at baseline were also associated with long COVID. When performing a latent class analysis to explore symptom clusters, three-class model emerged to be the best fit. The predominant class included patients with a broad range of symptoms. Patients with mental health symptoms such as anxiety and depression, alongside brain fog, formed another class constituting 14% of the long COVID cohort. Finally, a respiratory class of patients with cough, shortness of breath, and phlegm production in excess formed 6% of the long COVID group. In summary, symptoms of long COVID are broad-ranging and clustered together into distinct groups, possibly reflecting the phenotypes of long COVID that differ in pathophysiology, which ought to be explored further. Thank you very much. I'll now hand over to Utkarsh, the chair of this session.
Thank you, Anu. Thank you, everyone. This was a fantastic work that everybody has presented in their research. And it's fantastic to see that not only academics, but also people from industry are representing their research work. So I would just like to thank you guys and congratulate for the fantastic work that you guys have been doing. And I would like to pick a few themes that I noticed over the talks that everybody gave. The first thing is collaboration. So most of the work that the speakers have presented showed that the collaborative effort of what we had available was really important to the research that they did. In addition to that, the involvement of public and how the trust that the HDR UK in association with other funders have built that their data is protected, and how the trust has been growing. And not only the data and the work that they have done is going open source, meaning a lot of people who don't have access to these data or these codes, they can use these work for their personal research as well. And lastly, I would like to say the impact that these research have had on people across the country, not only in UK, but outside UK, across the globe as well. So these are some fantastic piece of work that our speakers have done. I would now like to say that the voting is now open, and you can see that notification might pop up on the top hand right side of your screen. You can either dismiss or you can vote it right now. So you will have 1 hour up until the lunch break at 2:15 to vote. And at the end of the day, in the annual award session, one of the speakers will be chosen as the winner of this lightning round talk based upon all the votings that have been made by you. So I'd like to thank everybody and would like to close this session and request you guys to have a lunch, and then we'll meet afterwards. Thank you.